I want to kind of kick off this conversation as a whole. A lot of different industries, sectors, organizations across the globe being affected by the pandemic as a whole, and there's drastic changes that have been shaping it. And so a lot in the patient health space as a whole and patient engagement. It's really interesting, how it's, a lot of times we think of, the digital affecting e-commerce as a whole and sales and Amazon and Walmart and Target, but in reality, there's multiple other industries that have been drastically affected. And so we got some great friends, great partners, supporters of the network over at Perficient as well as IBM. They agreed to jump on the phone today and kind of walk through a study that we did together across a series of over 100 different organizations and what's going on in this space. And so as we kind of kick off the conversation, Eric, I'll kick it over to you first. If you want to do, intro on yourself, organization, we can jump over to Tom, and then we can jump over to Brendan, who's on as well. And after that, we'll kind of jump into some of the content here. Sound good?
Great. Thanks, Aaron. So as Aaron said, I'm Eric Walk. I'm a director at Perficient in our data solutions practice. Perficient's a global digital consultancy. We work with clients sort of across the whole stack on their digital transformation, modernization, and data problems. My area of expertise is really around data content and knowledge, focusing on document processing, AI solutions, natural language solutions, with industry focuses in healthcare and financial services. I'm really excited to be here today and talking about this, and I'll pass it over to Tom.
Hi, everyone. My name is Tom Lennon. I am one of the leaders of Perficient's healthcare team. At Perficient, healthcare is a little over a third of our business. I've been with Perficient for, around 16 years, and 14 of those, I believe, has been really helping to understand and define and implement healthcare-related solutions in the IT space for our customers. And when we say healthcare, we mean predominantly payers and providers. As part of that, I've done a lot of work with IBM during that time frame, as well as many other vendors. Brendan Folks is with us today. So Brendan, do you want to introduce yourself?
Yeah, we'll try video one more time. Oh, it looks like it's stabilized. So fingers crossed. Good afternoon, everyone. Brendan Folks, and I'm our healthcare chief technology officer inside of IBM software. 25 years in healthcare IT. This is the only industry I've ever worked in, both provider, health plan, and sort of government social services. So it allows me really a bit of a unique view in how we try to approach problems. Software architect by background, and one of the ways we're all successful is by leveraging our partner network with a great partner like Perficient. Tom and I have known each other, I think, too many years now to count, and working on delivering successes, outcomes for our provider clients. So we're really looking forward to this discussion today. If I give a nursing point of view, it's because I was raised by one, so I was taught to think like one. So if you hear things that sound like you're nurses, it's because that's how I ended up in this industry in the first place.
Awesome. Yeah, I was just thinking that I was raised by a nurse as well. So tons of common here, and it'll be a great conversation. So just again, a reminder here, if you have any questions or comments along the way, don't hesitate to drop in the questions, the chat section there, or just email them in, Aaron, AARON at BWGConnect.com. So I think we're first going to kind of roll through a little bit around the study that we've done to kind of give you a baseline for the conversation as a whole. And so we surveyed just over 100 different organizations. Really, the meat of it there was over 50% mid-size or regional providers as a whole. Here's the whole breakdown. I'm not going to read through every single point that's on here, but 72% of respondents represented large enterprises. 69% organizations generated more than 100 million annually. So over-indexed a little bit to the larger organizations as a whole. And what's really interesting, a couple of things that we found out as we're doing this is when you think about, how they're prioritizing budget as a whole towards patient acquisition, huge focus, shift in the focus as a whole. But what didn't change was, if you look down here, that meaningful uptick in budgets for acquiring high value patients heading into the next year. So there is this idea that, hey, we all do want to over-index on patient acquisition, but there's not really a change to this, specifically around high value. Organizational maturity. I don't have to read, everything on these slides. I don't necessarily want to, but people are looking at how mature is your organization as a whole, organizations report to be most mature at the CMS, CRM, EMR integrations. I think that's not surprising as a whole. It's kind of the first part that people try to bite off. But as we look at these other stacks over here, they're kind of not a big difference as a whole. I don't know. I mean, I can kick it over to you, Eric, Tom, Brendan. I don't know if you guys have any thoughts here, but we can pause here briefly if anybody wants to jump in.
No, I think these ones, the best part of the conversation is yet to come, but these are ones that we needed that baseline of understanding, okay, they tackled meaningful use and some basic integrations and started to think about potentially a CRM that goes beyond your core EMR. That's everyone's thinking, but as you just were saying, Aaron, is everyone would like to go get it, they're just not sure how to go do what to go do next.
Yeah.
And one thing to add to that is, it's interesting in the survey that so many people are focused on that CMS, CRM, EMR integration, because what that really gives us the opportunity to integrate that data from the clinical events which occur and integrate that into the CRM and then use that to help message directly to patients to make sure that they're compliant, make sure that they're understanding, when their follow-up visit is, make sure that they're doing those things they need to do to help keep healthy, but also to reduce readmits, right? Things like that, to really look at how do we change the behavior by actively, going out and driving information to those patients. So.
Yeah, well, and how do we start that with sort of a baseline of rules, right, that are sort of fixed and hard coded, and add intelligence on top of that to start making predictions, right? Making predictions about what's the best way to get a response from someone, what's the best channel to talk to them over, which services are they most likely to actually come get, right, and come receive. So it gets into some really interesting questions that I think are only, we're only seeing the tip here. And it's going to be the beginning of a pretty big transformation looking forward for the industry.
Yeah, I think across the board, like when I kind of look at the data as a whole, we're at like digital 2.0 now, right? We have the baseline, we have the collection of the information, and we have the basics, kind of, starting to uptake in what we're doing. But that's not just, those are just table stakes now, right? We're at a point now where you need to leverage everything you're getting and all that information that you're collecting to get over here to a personalized experience as a whole. I think super interesting. If we jump in here, CRM usage as a whole. So on average, respondents reported to use 1.3, on average CRMs. 81% though said they'd like to go to a single one, right? And so I think picking that apart, everybody would agree, right? That's an ideal state of single, but how do people get there? Is it a reality? Is the other side of the equation? I don't know if anybody had any quick comments on this one, and we can keep rolling through here. I know there's a good chunk of the conversation, but this idea of jumping to a single one. Thoughts there?
Yeah, no, I think there's an opportunity to save some money there, right? And to optimize your operations there. But it is a question of how realistic it is and how much you're going to spend to get there. And so I think it's definitely can feel a little pie in the sky and feel like the ROI is too far away. But there's some interesting opportunities as you start to think about that, and replacing some sort of black box technology that comes with some of the less fully functional, less fully capable, but industry specific platforms, and looking at the more enterprise, full spectrum platforms that may not have those sort of baked in features that you need. So it's definitely going to be an interesting journey as folks go down that way.
And there's definitely value there, but it's hard to quantify, as Eric was just saying, the value of going to one electronic medical, one integrated platform really made sense. That was kind of an easy, well, there's nothing easy about putting in an EMR. I used to write them, I get it.
You know what you mean.
But it's an easy vision to articulate.
Right.
In engagement marketing, it's a little more abstract, the ROI statement. Is the cost benefit delta really going to be there? So of the 81% that see value in it, our advice to them is understand articulating what's your savings by retiring legacy applications, like some of these more black boxed, pre-configured things that lack flexibility, as Eric was describing. What are you paying a year in that one? Like that'd be an easy way to get to an ROI, because if you have one CRM, when your patients call or you try to engage them, it's from the people on the other end of the phone only have one place to look. So that could be a huge savings and a great experience for not only your call center employees, but your patients when they call in.
Well, 100%. I mean, Arvin jumps in here too, right? Just in the chat here, right? The single view of the customer, right?
Yes, that's exactly what it is. But there's only so much. You would love to have single view of the customer, but if you can't get there, there's ways around it.
Yeah.
And we did see a lot more emphasis some years ago, maybe 5 or 7 years ago, of really using multiple systems almost strategically because of the features and functions which are available, best of breed. But we're seeing that going away now, and really the maturity of the systems out there are able to handle more and do things in that single product.
Awesome. Just jumping down this side, CRM usage as a whole, the dominant use cases for CRMs continue to revolve around basic communications and tracking. We're seeing this, a meaningful rise in richer cases. I think that's kind of like this move to digital 2.0. Like, we have to look at this differently. We have this in place. I mean, kind of like you're saying that there's all these different little pieces as a whole that we kind of used because they were resident experts, but now, as there comes more holistic solutions, we have the opportunity, without all these different integrations, right, to actually make everything we're doing more powerful.
Yes.
So let's jump on to the next one as a whole as we keep going through here. This is kind of like the summary slide as a whole. So from the first couple slides, patient acquisition, personalization, engagement are becoming increasingly critical initiatives within healthcare organizations. 55%. I want to jump down to this, this one that says 55% plan or already utilized AI or machine learning capabilities for patient acquisition and personalization with different degrees of maturity. And do you have any plans to use, or are you already using AI or machine learning capabilities for patient acquisition and personalization? I mean, this is a huge jump from, I guess, probably a year and a half ago, where it was closer to probably 25-75. Is that something you guys are seeing across the board as well in the AI and the machine learning space? And then there's a lot of questions that come out of that when you remove humans from the interaction.
Yeah. There's definitely a lot of variation in the answer to this kind of question, industry by industry. The more heavily regulated the industry, the more concerns there are about privacy, about sensitive data, the more likely it is to be lagging, right? In the retail industry, right? This is, let's charge forward as fast as we can, right? In healthcare, it's certainly behind, lagging behind because of some of the concerns that you've listed here around data protection, around privacy, and most importantly around consent, right? When we start to use PHI in these kinds of modeling activities, we're talking about using it to market to a patient, right? If the patient hasn't consented to that, we've got problems. And so there's a number of issues that we sort of have to deal with, and it is a challenge, but they're all deal withable, as it were, right? If you put put your mind to it and work through it as an organizational change problem.
Yeah, I mean, if we jump into that, and so this is kind of as we get into the open discussion here as a whole. So if anybody has any questions, drop into the chat or the question section there, and we can get them answered or comments, and we can address them. But specifically around that, a lot of people have questions around the PHI, right? How is it protected? When you're using AI, when you're training it, right? And it's machine learning. How are you protecting it there? How do you see? Is it ending up in the CRM? Is it available? How do you protect it? It's just an interesting space that
and I think
4 years ago.
And the key thing, the way we always think about it, and we sort of more use the term trustworthy AI.
Yep.
Because if there's any violation of a patient's trust, you've lost everybody. whether you lose the nurses who are supposed to use it, the call center agents, the patients themselves. If we start with that foundation and a core belief of everything has to be trustworthy from the start, there's no hidden whatever else, you're not borrowing the data to go do something else. You start with that foundation at your core belief, you can start to overcome any of these objections to Eric's comment about deal with. I like that one. Because you're going to design a system with the proper security, privacy, consent, and almost borrowing a little bit of what we've done on the academic side. I mean, you think about the IRB protocols and things along those lines. To do a research study, you can borrow lessons learned from life sciences, from academia, as you're rolling out something on the production side. So that's the great thing about, you know, having the diversity across the healthcare life sciences ecosystem. You can borrow other examples to make sure that everything's secure when you're designing that trustworthy story.
Yeah.
And I think the other thing too is what AI ML, you know, is
exactly.
Are we just going to build an algorithm to see who we should reach out to? Or are we putting conversational AI techniques into an interactive experience?
Yep.
All of them are good options, but that's another thing is what technology, where do you want to start? Because there's different ways to attack this.
Well, and how are you going to control the deployment to control the data, right? You know, there are CRM options out there that have the proper certifications and security controls in place to allow you to load your PHI in there and secure it and control it appropriately. But even so, that may not be an option for any given organization. And how can we take the AI and the machine learning models and bring them to where the data is, right? So we have fewer concerns about shipping the data to other places for training and other places for executing those models, and we can you know, more tightly control how that data is being sent, where it's being sent, and how it's being used.
Yeah, that governance is important, especially as you put it, you know, where we're going to send that data, making sure that we're able to limit the exposure in one place and send the information that doesn't have that exposure all over the place. Because trying to manage that when it gets throughout your entire organization can be quite tricky, right?
Yeah. Yeah, and having tools that you can deploy where you need them is really important, right? Knowing, you know, especially as you're looking at cloud strategies and those sorts of things, right? You can choose solutions that are cloud native. You're going to have more challenges in terms of just making sure you understand the way in which each of those solutions controls PHI and secures PHI, because a good number of them are compliant in various ways. Or you can look to other options that allow you to maintain trust through the whole chain of custody of the data by using, you know, possibly more complex and more nuanced solutions, but that allow you to take your modeling and do it where you need to do it when you need to do it.
There's so Ranjan writes in, you know, 55%, you know, it seems high unless we're talking about automation versus AI, which is, I think, kind of a little bit you're getting to. There's, hey, how are we mining? Or are we actually just using AI to engage in a conversation, which kind of gets to the patient engagement side of things. But I would like flip that a little bit and said, I think 55 seems low at the point that we're at right now, that 45% would say they don't have plans to or don't already, to not be looking at it. Like, I should say 45% seems, that's high. It seems like 55 would be 85 or 90 would be considering it.
Yeah.
At least
if this were any industry other than healthcare that we're looking at, I would agree, but it doesn't shock me for healthcare.
Because that security mindset also is going to, I think, keep that the yellow side, the 45%, where, you know, it's not actively being planned to use higher. I actually think in the 55%, that's still more people from our experience with customers is probably more along the lines of people planning and beginning to use it as opposed to, you know, actively using true AI in it, unless you start to count where there's AI built into some of the tools that they're purchasing, which could have some of that included. But I think that's what we've seen more of so far, is less people actively using AI and building their own models, more using, what's built into the vendor tool, or planning to getting their infrastructure in place to be able to start leveraging AI in a safe and manageable way.
Yeah, and I think too, it's a great point. Was it automation or AI from the person from the audience? I think if we asked them would they like to automate some of this, I think the answer would be 100%.
Yeah.
Now, where there's AI, there's automation. Where there's automation, there can be AI. It's a very symbiotic story. I wonder if the no plans number, which is, I agree, Aaron, it's probably still kind of high at 45 without having plans. We have to remember that of our respondents, they have been through a perfect storm, tsunami. Just, they're probably pretty drained at the moment, from the past 18 months and the recent uptick. Our provider community, we have to be very thoughtful about approaching them, about helping them with things, because they're just under this wave. I live in Massachusetts. I'm actually in an office today in New York City. I'm at 590 Madison. But in the state of Massachusetts, we just had a bill go through that the hospitals agreed to push back elective surgeries due to the rise in cases. So there may be a COVID hangover to this 45% number being so high, is people don't want to take on anything new until they know what's actually going to be, what's going to happen.
Yeah.
I don't know if that's the case, but that could be one of the reasons why people still don't have plans around innovation on patient engagement, because their teams are still just drowning and trying to survive, as we get hit again, it seems.
Yeah.
So a great comment comes in. A number of healthcare organizations are using AI for RPA applications too. It's kind of a different purpose. I don't know if there's any comments there, but I have another question that comes in as well that I'd like to jump out to. But any thoughts on using AI for RPA applications?
Yeah, I mean, those two sorts of things are synonymous, right? You don't really have RPA without AI. RPA is it's a cool set of technologies that could be really powerful in a lot of cases, and give you sort of quick time to value on certain kinds of quick wins. But I think it's an interesting space and an interesting way to start automating, right? You can get going quick, and there's always, though, the next stage, right, where you can get better results if you put in a bigger investment, look at some different kinds of technologies, and automate it in a more thorough way.
So when we think about patient engagement as a whole, right? There's the initial outreach side. So questions around how you can use PHI to make predictions for marketing purposes. We still have the concern about storing that in a CRM, right? Or whatever marketing automation platform you might have. Any thoughts there about how we can utilize it to do outreach? I mean, patient acquisition, one of the top ones, I mean, the first slide we did is shifting. It's a major focus going forward. It was probably a top indicator there. Would love to hear your thoughts there.
So I think it's a little bit of back to the trustworthy AI and having problems that are overcomable, or whatever we called it, Derek, but doable. But the thought is, where you go to build these techniques, I think, is where a separate platform somewhere fits in, because you can put all the security and privacy in your data science environment. Data can be obfuscated, masked, still with relevancy enough so that the model's trained properly. You learn how to design that program, and then that scoring model, you just push the scoring model to the CRM. You don't try to do that inside the CRM, because that's not what it's meant to do. It's not a data science platform. It's not an AI platform, machine learning platform. They're very, very good at what they do. This is where augmenting them with skill sets, people like Eric and his team, and the right piece of technology then augments the work you do in the CRM. But to that automation piece, I think that's so key, is what can we automate to allow your high value employees free up to do high value things? And we do it in operations. We're talking about specifically this survey too is about engagement. And I don't think we've really touched on where we could free people up to provide more bandwidth for better engagement.
Right. Well, yeah, I mean, an example that I was thinking about is because one of the comments in the study brought up the digital divide, right? And the idea that there's high value patients that are easy to reach with an email who will come consume high value services. But there's also a whole population of patients that we need to reach who may not be your highest value service consumers, but still need healthcare, right? And still need to be contacted and communicated with appropriately. And one of the things that struck me is how do we, instead of just predicting who's going to consume high value services, can we start to predict how to best communicate with someone, what kind of communication they're going to respond well to, right? There's a lot of ways that we can use this technology to make predictions. And it really is data science, right? We are really doing experiments, right? To try to figure out, given the data we have, what kind of predictions can we make? Can we do that in an ethical way? Brendan mentioned earlier the idea that we could learn something from the IRB process, right? As we start to go through this in order to maintain an ethical stance as we go forward and build this in a way that's trustworthy and makes predictions that are, you think about saving time, right? If we can predict that a particular person isn't going to respond well to a phone call, let's take them off the list for phone calls, right? If we can predict that someone's the best way to reach out to them is, knocking on their front door, then let's go do that, right? Let's use our resources where they're going to be most valuable and where we're going to see the best outcomes.
Yeah, and it's interesting you just mentioned that digital divide, Eric. That was the one I knew we were going to get to it, but since you set it up, is we were talking about engagement strategies and technology, and it's amazing that the respondents very quickly jumped into an equity discussion, a health equity, equitable distribution of healthcare. Where does social determinants fit in? And that's something we're really seeing. What did we see over the past 18 months? Our most vulnerable took the worst beating.
Yeah.
And where does that become? And it was interesting this morning. I was reading something this morning on that topic. It fits right in. Is Dr. Stephen Klasko, who's the soon-to-be retiring CEO at Jefferson Health, published something on the World Economic Forum this morning around broadband access now fitting into the category of social determinants. Because if we want to engage with virtual care, because it works, we know it worked. We saw that huge 5,000% increase in telehealth start to dial back down again. It's not good if you don't have access. And it really came in. I wasn't surprised it came up, but based on the questions we asked, how quickly people went there.
Yeah. It's a real problem. Oh, go ahead, Tom.
Go ahead, Tom.
Okay, and with using social determinants too, right? Especially as we start to push it into AI and leverage that in AI, just because you're using that information doesn't mean that you're going to drive that equity, because the bias that is inherent within AI, until you can manage it and normalize it, that bias is still going to be there. So really learning how to use that and adapt it is important, because that has opportunity for us to really help address some of that inequality, but it also has the opportunity that it could make it worse, because AI doesn't have the same feeling and natural intelligence, right, as we would have when we're worried about different or groups within our population.
Yeah, well, that's where it's really important to to think about the tools you're picking, right? Some AI tools have capabilities that help you identify bias in your models. Others don't. Those priorities are critical as you're sort of looking at the tools you're using, looking at the way you're designing your models and thinking about building models, but also educating your data scientists, right? As you're training your people, because people build the models, people build the algorithms, people train the algorithms. It's also critical to train those people to think about these things and be concerned about them and look out for the warning signs that there's an issue in a model. That's exacerbating historical inequality.
Where do you think that this percentage shifts over the next year to 2 years? Do you think it stays here, just getting back to some of the comments around people are inundated, or do you think this changes a lot?
So I think it's going to continue to shift upwards. And part of the reason why is if you ask the health plan community, they're 100% focused on doing this.
Yep.
So it makes sense because the providers are still the trusted partner. Providers and pharmacists are still a patient's most trusted advisor. So I think that trust factor that they have gives them an edge in engaging patients. Now, maybe they should collaborate. There's a skills gap. Maybe they can partner with some of their health plan, when they get into value-based arrangements, they could do some more collaborative effort on this to leverage each other's shared trust as a thought to improve engagement, because we know the health plan community is trying to do this every day. It's actually why I'm here in New York. We were setting together a strategy for this exact problem, but from a health plan's point of view today. There was a bunch of us sitting in a room whiteboarding the whole architecture out, but that's the thought process. They're focused on it. So providers should be, because they're still, when it comes down to it, do you want to hear from NYU or Emblem? I'm in New York City, so I'm using New York examples as a patient. It's just, it's a real, a lot of health plans are moving to try to really adjust that trust factor, but that's a topic for a different day.
Yeah. I agree. I see it going up. It's certainly not going to go down, and I don't expect it to be static. Aside from the health plan factor, right? As things level out, right? Every indication is that pandemic is becoming endemic. This is a forever problem, not a problem that's going to end one day. Very suddenly, it's going to whimper.
And there goes my Christmas. Thanks. No, just kidding.
But it will stabilize, right? And as the situation stabilizes, the question that folks are going to be asking is, how do we be ready for something like this to happen again? How do we be ready? How can we be ready for future challenges where we need to be technologically prepared to do new and different things, using these kinds of tools and technologies to engage with patients, to understand patients better, right? Because it's sort of two sides, right? As we provide a patient with a more personalized experience and more personalized outreach when we're trying to get them to come in and consume services, that exercise in itself helps us learn about our patients, helps us learn more about where they are, how they consume services, what kind of things they drive them, what kind of access they have to things like broadband, things like the ability to get to the hospital, to get to the care provider. So how can we take advantage of learning these new things about our patients into the future as we build our preparedness plans for future crises, but also for our day-to-day operations?
Yeah, and it also comes down to resources, right? I mean, we have different size and shape of organizations that have different resources, and I think it's probably universal to think that, well, where we can use the tools to help lighten the load of a lot of the folks within that provider organization, great, but it takes resources to get that ball rolling, to gain that momentum. And so when will that happen? Some organizations have seen the opportunity to take advantage of that already, more on the larger size providers. The smaller providers typically have a little more difficulty making I guess getting some wind at their back in that situation.
Yeah, things we think about in terms of lightening the load, right? Or really, sometimes it's less about lightening the load and more about transitioning the worker to doing higher value things, right? Going back to a call center situation, right? Can we use this kind of technology to divert calls away from the call center, right? And handle them in an automated way? Sure, but we're never going to get to 100% on that, right? There's always going to be some need for a human to pick up the phone and talk to someone. But can we use some of this predictive modeling to make predictions about why that person's calling, what information might be relevant to that call center worker, so that we can make the experience for the call center worker more intelligent, more intuitive, right? So that they can handle that call faster, more pleasantly, less putting someone on hold while they go look something up or call phone a friend. How can we automate that process more? So even when there's still a human in the loop doing the service, right, answering the phone, talking to the patient, that's more seamless, more smooth, easier for that person answering the phone to be more caring, more trustworthy, and build a better relationship with the patients.
Yeah, and that's a really good point, because Tom, you mentioned it first, is resources. Yeah. The unemployment numbers in this country are at historic lows. The use of traveling nurses is through the roof. There's a skills warfare out there. And when you start thinking about innovative technologies, sometimes those people are harder to come by. And that's where we always like to compliment, strengthening, find a win at your back. But that's a very good point Eric makes too, is let's take engagement can be about human to human, so it's okay.
Yeah.
Actually, in certain cases, it's preferred. But if you've done something up front to more educate your patient before they call via conversational AI, they get 2 or 3 questions answered, and they call about a third. Or like Eric was just saying, you make the agent's experience that much better, so they can be more efficient and make the members, get the questions answered, especially now because call centers had to go remote.
Yeah.
So phoning a friend you can't lean over to the next cubicle and get an answer because there's nobody there but your kids down the hall, So it's, how do we empower those people? No, nope. They're the ones using up the broadband in the house playing video games.
Right.
But yeah, if you can better use these tools and techniques internally to more empower those people, well, that's going to give the patient a better experience when they call in, even if it's just something simple as scheduling.
Yep.
What's the hard? It's like this magic scheduling thing that happens inside healthcare. So, don't tell anybody how it works. Let's try to make that easier for the schedulers.
Yeah, just a quick reminder, I have some questions coming in, but if you have questions, drop into the question section, the chat, or the Q&A. But I think it's a great point that, so often we think of AI as just, spewing out information and targeting and using it for marketing, which is good. But patient, engagement, the ability to use that internally as well, where still the communication happens person to person, but acquiring all that information up front can be facilitated. And that jumps into just a question around, like, is this an ROI question then right now that people are struggling with? What is the return on this, right? Time, effort, money, right? And all are stretched thin right now. How do I pull the trigger on this, one more thing? And what does the ROI look like as a whole? I mean, Eric, I was just thinking about that while you were talking about, moving people to higher value, tasks. How tangible is it, the ROI in the end?
I mean, it depends on what you decide to implement, right? But let's say, we implement a conversational AI system, right, that can handle 80% of scheduling, right, of appointment scheduling. Well, now we take that from entirely a situation where people are talking to a human on the phone who's looking at a calendar and trying to figure it out, right, to a situation where 80% of those calls are diverted. The 20% that get through have complicated problems that need a human to look at them, right? And then that human, maybe you don't reduce that person's cost, but they can spend more time working on each issue, right? Maybe you can give them the ability to do a better job figuring out those complicated scheduling problems, right? So that the patient experience is improved, and now the patients want to come, have a higher perception of your organization, of your hospital, right? And are more willing to come back to you, refer you to friends. But at the same time, you could also, look at it as a way to reduce some headcount in different places, reduce some technology load in other places. But it really depends on what you want to implement, right? And how you attack it first.
And that immediately measurable ROI is also, you should, I guess, open the aperture a little bit too, and think about the better we can engage patients, the quicker we can do that, the way we can change their behavior can have such a dramatic impact on the overall margin or bottom line of the provider organization when we think about population health and involvement in ACOs and different, payment models. where they're actually going to change the way the care is delivered and reduce the overall cost that might not be so apparent at the system or project or program level.
Yeah, that's a good point about with the accountable care organizations, and really, using some of this to reduce the per member per month overall rate, right? To try to achieve some savings there.
Yeah, but that's a good point though, Aaron. Sometimes why is the 45% still so big is that ability to define the ROI. And I always love that. So what does success look like when you're having these conversations? Having a definable metric. And if we're doing call centers, Eric was saying, we're discussing that. Well, there's metrics there that are pretty easily and widely accepted: cost per call, number of calls, deflections, average handle time. You can put some hard ROI around that. And people do sort of cost sharing agreements to try to pull these things off. But other ones are sometimes a little harder. But our recommendation, our experience is, let's agree what success looks like before you define the use case you want to chase. Anecdotally, there's such a wealth of information in all these providers on what we could be doing better. And we don't pretend, we've all been in this industry a long time, but we don't pretend to know how to run your business better than you do. Our recommendation is define what the outcome is you want to measure, because you can't fix what you can't measure. So we need something we need to measure to prove it worked. And then that success will build on itself. People will do case studies. You'll go out on the speaking circuit. You'll be on one of these webinars, and that blue number will start to come up as they hear about their peers doing other things, and that it can be done in smaller chunks.
Yeah. So, it is a really good point that you can do this use case by use case, right? You can tackle one challenge in one area with this kind of technology and slowly expand it out, right? And the overhead, the upfront cost of dealing with security concerns, dealing with the ethical concerns, dealing with all of that is it's lower than you might expect if your use case is sufficiently simple, right? And once you get a simple use case going, right, dealing with the additional concerns of more complicated use cases becomes incremental costs, not the overhead there is not going to be huge, and it's not going to sink your plan to expand out into other areas there.
Are you walking people through that then? Because I think a lot of just, having, run this survey as a whole, a lot of people, think it's this massive undertaking, right? That you're ripping everything out, you're putting something new in, or it's such a huge, just undertaking as a whole. But I don't have the time, effort, money to go after this right now. So are you kind of walking them through and saying, hey, yeah, there's 57 different ways you can use it, but the first 3 are really easy and it's worth giving a try. Like, are you breaking it down for people that way?
Yeah, I think I call it crawl, walk, run. Other people use it land and expand, start small, whatever metaphor you want to use. There's a way to take something simple. And an example for one organization was like, can we predict a group of people that might be non-adherent in their medication plan for something simple? It was actually middle-aged men not taking blood pressure medication, not taking hypertensives. Probably a good group to go after, right? Because other things will happen. Well, if you looked at socioeconomic factors in that model and we predicted non-adherence, you would just ship them a 3-month supply and give them a call and tell them it's coming. Like, it's not a complex prediction. It didn't take a lot of work, and the outcome isn't. What's a generic cost? The 3-month generic, it's going to cost you what, $30 to keep somebody adherent?
Yeah.
So there still is true machine learning in the model. We did a whole scatter plot, we looked at random forest, we looked at all these different techniques and picked the right model that was most accurate. But it wasn't a really complex use case. It was just a different way of using the data they have and then helping them automate something to drive a benefit at the same time.
Yeah.
So it is all about crawl, walk, run.
Well, and what action, right? Because you know, sometimes that creative thinking about, okay, what if we just shipped them their medication, right, and didn't charge them for it? How, you know, coming up with those little things you can do is often the hardest part, right? It's finding that use case.
So are there other things that came up, as we're getting here to the last, 5 or 6 minutes or so? Eric, I know you'd brought something up out of the study. Obviously, we couldn't tackle everything in this summary that we had. Were there other things that stood out to you that you thought, hey, this was really a highlight for me? We kind of do a roundtable here, like, hey, these are key things that people should be thinking about, things that stood out for you in the study, or things that people, should be planning for next year. We can kind of go around. Eric, I'll start with you, and then we go, Tom and then Brendan.
Yeah, I mentioned I think we all sort of were really intrigued by how quickly the issues of digital divide and health equity came up. But I was also impressed by the strength of the signal in certain areas. I think more people are more interested in doing these kinds of things than even we predicted. We wouldn't have done the study if we didn't think there was interest, but I think the interest is stronger than we were expecting, and I think that's really really compelling. But I think something I said earlier, right? Active, explicit, and informed consent when we work with our patients and to use their data for these things is really important. And I think that's sort of the starting point of that trusted AI and sort of where we're going to be going here into the future. And it helps address a lot of the concerns that we saw through the study around compliance, right? Where, ultimately when the patients have given their consent, we have a lot of flexibility to do things, but we do have to make sure we're dealing with that appropriately.
Yeah. Awesome. Tom, anything that stood out to you?
Sure. So we talked a lot about trustworthiness of the data, right? Well, one of the things that really caught my eye was multiple mentions in the survey about situations where people aren't sure that they're getting the right patient. Have they identified the right patient? Or are they somehow mixing them up? You might have consent, right? So it's a great point Eric made, but then if you send the wrong information to the wrong person, that's a problem. So what are the ways, what are we going to do about that and make sure we can increase the confidence there? And there are, and part of it was answered by other people's comments, and so using third-party data, for instance, and we've seen a lot of that. And the tooling, whether it be tools that come with your CRM to do some matching, or full-on, MDM, EMPI tooling or whatnot, and the advances there and the use of AI within those tools. But one thing as well is using that third-party data where you can do referential matching. Starting to use bio identity matching, things like fingerprints and face recognition, and eventually even gesture on a device, things like that, and start to incorporate that to really change the game on how they can elevate that matching percentage. And we have the tools now that are, some of them have been around for a long time and have seen advancement, and others are relatively new or new ways of using those tools. But that it's a critical measure, but it's also something that's attainable and worthwhile.
It's super interesting. Just made me think of like digital identities as a whole, and in other areas, your digital identity gets morphed into an avatar and into the metaverse, and where all of this could be going in reality, right? Is into a portal where digital identity is all locked up in blockchain and
And we're talking more and more about things like that.
Well, we just went to that's a different webinar. We're going to start talking about a network of networks and immutable records and things along those lines. But I think the thing that stood out to me, obviously we talked about that social divide. It was interesting. We did a study on that one with the Blues Network. We had 39 of the 50 states represented, and this idea of engagement around equitable distribution of health was top of mind at every C-suite, every single one of them. And they were trying to use techniques to it. But what's interesting though too is what the other thing that stood out was they didn't use the word like bias, but they used words like, well, I have multilingual, bilingual, 40% Spanish. What do I need to do that's non-traditional to work across these these new mediums, and people are thinking about innovative ways to do it. I think that was exciting. People were willing to engage across these large enterprises because this is a topic that matters.
Yeah.
It is creating a pivot, whatever the number is on the circle chart, but they're thinking about the nuances of trying to do this. And Tom mentioned it earlier. They didn't use the word bias, but we have to make sure that there's not bias in the data. You know, as I'm sitting here, and I'm from Boston, but I love New York City, especially from a healthcare. It is nowhere else on the planet do you have a microcosm of all of the world's populations in such a small area. And how do you engage this massive population and then treat them and care for them differently? That's the fun part. That's why there's so many academic medical centers here, because you can study anything in New York. But it's one of those things but you have to think about that, the population you are trying to target, to make sure there's not bias in the data if we're trying to do some of these innovative techniques. But that comes back to trustworthy, all those other things. People know how to help you do this. We can advise you, other people. These are important things. And the fact that they're excited about it, hence the participation, people here today, everyone's thinking about it. So let's go see if we can try to solve some of these.
Yeah, awesome. Well, thanks. As we get to the end here, awesome conversation. Eric, Tom, Brendan, thanks so much for jumping on. This study was incredibly insightful. If anybody wants a follow-up conversation with anybody on the line here, 100% worth your time. I think it's worth doing that deep dive on, hey, what's step 1, 2, 3 if you're just getting into it. You don't have to eat the elephant in one bite. I guess you can eat it one bite at a time. And these are the people out there that are leading the space that come highly recommended from throughout the network. So 100% worth putting some time on the calendar. With that, I think we're going to wrap it up. Thanks to everybody who sent in a great conversation, great talking points, great questions. Thanks again, Eric, Tom, Brendan. We're going to wrap it up here. Hope everybody has a fantastic Thursday. Everybody take care, stay safe, and look forward to having you at a future event. All righty. Thanks, Steve.
Thanks, guys. Thanks, everybody.